So I'd like to start, though, by going back to the Vladeck article with which I ended last time. And I want to remind you that Vladeck was a very important figure in the Clinton administration. He was the guy who ran CMS, which is the federal agency that oversees Medicare and Medicaid. He did an extraordinarily good job. He's a very good administrator. He's a very smart guy. He has analytical training in political science and deep knowledge in healthcare. And he applies both his knowledge of healthcare and his understanding of political science in a couple of articles that are on Blackboard, one which was on Blackboard for last week, and one that will be coming up at the very end of the semester where he really applies his political science acumen to understanding why things are so difficult to change in the United States based on our constitutional system and other political realities. Here he's looking back from 2001 to what happened in 1965. And he makes two major points. One point is that there was an unusual opportunity in 1965 because of the landslide victory in 1964 in which Lyndon Johnson was swept in as president by a huge majority, and Congress became even more democratic than it had been. And this shifted a lot of things around in the political possibilities of Washington and the policymaking. And yet, he laments, looking back with 20/20 hindsight, that the people who had the opportunity to do something really dramatic, bold, even radical in the American context, of moving towards a universal healthcare system across the age spectrum, did not do that. And he laments that they had an opportunity that they missed, that they failed to respond to their opportunity of political circumstances, an exogenous change, as he calls it, that essentially radically transformed the possibilities, the dynamics of American political life. They failed to see because they were myopic, they had limited vision, and they were cowardly. They lacked full courage. He tries to pardon them by saying, well, the key leaders of this, a man called Falk, a man called Wilbur Cohn, who was in fact the Undersecretary for Health in the Johnson administration and was the key figure when all this was happening and went into legislation and implementation, that they had grown up professionally in the Social Security Administration. They had worked for it, Falk, since its beginning in 1935. And they watched how the Social Security Act, which passed by a significant majority in 1935, but only because the United States was, and the Western capitalist world in general, was in a great crisis of the Depression and felt that they needed desperate measures for desperate times. It was only then that the United States caught up with what Germany had done 50 years before with the Bismarck social welfare legislation and passed the momentous Social Security Act of 1935. There was then the Social Security Administration created as a bureaucratic entity to administer that act and see it go through whatever modifications it may have needed, worked with legislators to get amendments to modify the... And they saw that Social Security, from its first base of acceptance, was able to add things and grow incrementally. So their reality was that of incremental change, slow, painful incremental change. And when they got out of that particular comfort zone and they supported the Wagner-Murray-Dingell bills to try to get a universal health care program under the leadership of President Truman, they got beaten back. And it's only when these very clever guys came up with the Medicare strategy as an alternative. In the United States, we're not going to be able to do it for the population at large at this point, but we can have a major step forward, a big increment, if we can cover those over 65, and there are various factors contributing to that. Those folks have obvious need, they have earned their right to being taken care of, they have been good working men, they now reach retirement, where they're older and they're going to be without insurance just at the wrong time, and things are getting expensive, so we surely can take care of them. It took them 15 years from first conceiving those notions in the early 50s and finding cooperative legislatures like Foran first and then King and Anderson later to sponsor legislation along those lines. It took a very long time to get to the point where, with the help of exogenous events, that landslide victory of Johnson, also electing this newly powerful Democratic Congress, it was only then that they were able to put that into action, and it seemed to convince them that, well, the incremental method was really the right way to proceed. Because perhaps on this basis, once we have a plan universal tied to Social Security with earned entitlement as the principle, the same in every state as a federal program, not as a welfare measure, but as an earned social entitlement, then we would be able to build on that and maybe extend through the age spectrum and so on. That was their vision. Vladeck says that was a very limited vision. That was a myopic vision. That was perhaps a cowardly vision. And this is what he writes on page 156 of that article. The logjam over Medicare was broken by exogenous events, the Democratic landslide of 1964, which radically, if briefly, altered the political landscape. But the potential inherent in that change was understood best not by Medicare supporters, these guys who had lived their professional lives in the Social Security Administration, but by their arch enemy, Chairman Wilbur Mills. Wilbur Mills was a very conservative Southern Democrat who was chairman of the House Ways and Means Committee and had bottled up Medicare legislation. He hated it, he didn't like it, he saw the implications of it. And he, with Kerr, had proposed the alternative, Kerr-Mills, which was based on a very different state-based and welfare-oriented system that was meant to be an alternative and a political response, which had very limited application and very limited success, just as the liberals had predicted. So Mills was very wary of Medicare. And when he helped craft the compromise that included in the final Medicare legislation not only the original mandatory hospital insurance, but voluntary physician insurance, Medicare Part B, which the AMA had first proposed and legislators had supported, etc. But also put into it a very extended, expanded version of Kerr-Mills. That is a Medicaid welfare-like program, state-based, but extended through the age spectrum, not just for poor elderly, for all poor, theoretically. It didn't always work that way, especially in the South, where Mills came from. But when he was able to put those two additional pieces in and built a three-layer cake, that's a three-layer cake, he knew and explicitly stated that by doing so, he was building a containment wall around Medicare, Part A, and its possible extension and expansion into a universal health care program through the age spectrum, which he knew the liberals nurtured, cherished, hoped for, but didn't yet come out with. It was the arch enemy of those liberals who saw the radical possibilities and deliberately tried to protect against it, to counter it, by building containment walls, fences around Medicare. Okay, big wall along the southern border. Big wall, okay. I don't know, I slipped into it by some reason. Anyway, this is what Vladeck says about that. The question of whether Medicare's founders, caught up in the assumptions and preconceptions of a 15-year struggle, had perhaps failed to seize the moment provided by LBJ's landslide, and were thus only too happy to settle for what Mills differed, which Mills offered them, rather than what they could have gotten had they correctly read the nature of their political opportunity. It was Mills who saw the revolutionary potential of a universal program at that moment and built containment fences to protect against it. He saw it, but the liberal proponents didn't, either because they lacked vision or they lacked courage. So that's the main point there, and he comes back to that point at the end of the article where he makes clear that those who were promoting Medicare saw that as part of a incremental process, and they failed to have, as he puts it on page 160, the vision and the foresight to see that non-incremental changes, if packaged in the appropriate rhetoric and responsive to short-term grievances, was not only possible but attainable. They failed to see that. And such windows of opportunity come at best every 30 years. That's why he's glad Wilbur Mills wasn't around in 1994 to see the fiasco that the Clintons made of their 30-year opportunity, or roughly 29 years in 1994, when the Clinton proposals went belly up very quickly, and we'll get to that later. He's glad they weren't around. It would have been too heartbreaking for them. Okay? But then he ends on this note. That's the general content. There are only two conclusions that one can draw from this perspective. And that is, one, we should consider ourselves lucky in this very conservative country with its very well-articulated political mechanisms designed to frustrate change, to have achieved Medicare at all, and to have protected it so far from the assaults of its unreconstructed opponents. And then the second, of course, we better make sure that if we ever have that opportunity again, which may be coming up in 2025, if we follow this 30-year rule, that's obviously hard and fast, to blow the opportunity if you have it again. But the first part is what I think is particularly striking. We should consider ourselves lucky in this very conservative country with its very well-articulated political mechanisms designed to frustrate change, to have achieved Medicare at all, and to have protected it thus far. Well, what does that say? It says that if you are an astute observer and compare the United States to other advanced, as Reed calls them on the cover of his book, Better Achieving Healthcare, this is the healing of America, or he says it on the film, sorry. Other rich countries have universal health care. We're talking about financially, economically advanced, democratically institutionalized countries like Great Britain, France, Germany, and then there are others that are covered in the film, Japan. We're also looking at Taiwan, and there are some others that get passing mention. And to add to that group, easily Denmark, which seems to be Bernie's favorite country, Bernie Sanders, when he looks at social legislation in advanced and enlightened European countries and so on. These seem much more attuned to their citizens' needs than the U.S. They are all capitalist countries, without question. And you can add Scandinavian countries, Sweden and Finland, and certainly you can add, well, Denmark is sort of in that Scandinavian group, in the Netherlands and so on. These are all capitalist countries. And in the southeast you have Japan and Taiwan and etc., other countries which have universal health care systems. But they are capitalist countries which seem to have found a way through democratic means and democratic institutions to make a commitment to covering their populations universally. And that's something that really bothers and puzzles T.R. Reid. He gave us a little epitome of what you will see in the film and read in his book in an article that Newsweek invited him to publish there in their September 21st, 2009 edition. It was timed to appear soon after his book just came out, so of course he delightfully accepted the invitation since it's free publicity for his book and also a chance to get his message out. So this is what T.R. Reid says as his distilled summary in his Newsweek article, which is very close in principle, and you'll hear about some of the same people who will appear in the book and will be on camera in the film, and so on, especially the Swiss President Kouchner, who he quotes very effectively here. This is what he says. He says, the design of any country's health care system involves political, medical, and economic decisions. But the primary issue for any health care system is a moral question. Should a rich society, and these are all rich societies, certainly in standing to the rest of the world. These are the European OECD countries with the United States. These are all rich societies with democratic institutions and democratic political procedures. Should a rich society provide health care for everyone who needs it? If a nation answers yes to that moral question, it's a fundamental moral question, it will build a healthcare system like the ones in Britain, Germany, Canada, France, Japan, where everybody is covered. If a nation doesn't decide to provide universal coverage, then you're likely to end up with a system where some people get the finest medical care on earth in the finest hospitals, and tens of thousands of others are left to die for lack of care. Without that moral commitment of those other countries, in other words, you end up with a system like America's, a system that lacks that moral center. And then he continues a little further in the article. The most important influence of national culture can be seen in the most basic question facing any country's healthcare system. Who is covered? On this fundamental issue, the United States is the odd man out among the world's advanced free market democracies, and all those other countries are free market democracies. All the other industrialized democracies guarantee health care for everybody, young or old, sick or well, rich or poor, native or immigrant. Take that, Mr. Trump. The USA, the world's richest and most powerful nation, is the only advanced country that has never made a commitment to provide medical care to everyone who needs it. Sad but true. Our lack of universal coverage has consequences. According to government and private studies, about 22,000 of our fellow Americans die each year of treatable diseases because they lack insurance and can't afford a doctor. That's been changed some by the Affordable Care Act, but not gone away. This generally happens to people with a chronic illness who have too much money to qualify for Medicaid, but too little to pay for drugs and treatment that they need to stay alive. Among the rich nations, this happens only in America. Likewise, the U.S. is the only developed country where medical bankruptcies can occur. Those Americans who die or go broke because they happen to get sick represent a basic moral decision. Keeps coming back to morality as the central issue that our country has made. All the other rich countries have made a different decision. They cover everybody. A French doctor, Dr. Valérie Newman, explained it this way, and imagine this is in any French accent. You Americans say that everybody is equal, she says, but that is not so. So brutally, honestly French. Some are beautiful, some are not. Yeah, that's the way it goes. Yeah. Some are brilliant, some are dumb as stones. Yeah, so it goes. Huh? But when you get sick, then yes, everybody is equal, or should be at that time. Beautiful or ugly, smart or dumb. Everyone has an equal social need, an equal personal need, and it's society's responsibility to respond to it. That is something we can deal with on an equal basis. This rule seems so basic to the French and to those other countries. We should all have the same access to care when it comes to life and death. Other nations adhere to the same principle with slightly different explanations. For Switzerland, and remember, Switzerland, as Reed points out, is a rich, capitalist country that didn't create universal health care until 1994. Coincidentally and ironically, the same year that the Clinton plan was failing utterly. The underlying rationale of the concept is solidarity, solidarity. It's a key concept, a key word that will be running through the film and the book that you're about to see and read. That's a crucial word in the Swiss vocabulary, freighted with meanings that include community, equal treatment, and despite our differences, we're all in this together. To have a great sense of solidarity among the people, former Swiss President Pascal Couchepin, he was the president when the new Lamal, the health sickness law, went into effect, he said all must have an equal right, and particularly a right to medical care, because it is a... Now, important thing about Cushman, he did not come from the left end of the political spectrum. He was a conservative political figure, and initially he opposed the new sickness insurance law, but in the process of rational debate and discussion, he came along and came to support this measure as in the best interest of Switzerland and its citizens, and became a strong defender of it, even though he came from the right end of the Swiss political spectrum. That's very important to remember. To have a great sense of solidarity among the people, he told me, all must have an equal right, and particularly a right to medical care, because it's a profound need for the people. And if they are struck by the stroke of destiny, then at least they can have a good health care system to take care of them. The principle seems so obvious to people in Europe, Canada, and East Asian democracies that health officials asked me over and over again when he visited with them and spoke with them to explain, why isn't it obvious to Americans as well? The formula is so simple. Health care for everybody, paid for by everybody. A deputy health minister in Sweden told me, you Americans are so clever. Why haven't you figured that out? We have. You're supposed to be so smart. Why are you so dumb about this question? This formula is so basic in the other industrialized democracies that virtually all of them have included some version of a right to health care in the national constitution. Nearly all European countries have signed on to the European Union's Charter of Fundamental Rights, which serves as a sort of continent-wide Bill of Rights enforceable by the courts. Everyone has the right of access to preventive health care and the right to benefit from medical treatment, the Charter says. That's it. Everyone has the right to health care. Then he ends by saying, in the U.S., by contrast, neither the federal Constitution nor any state guarantees health care for all. And it is not in the Affordable Care Act. That is one of my very strong criticisms of it. It doesn't even attempt to establish that right. It is a market fix. It is a filling in of holes in a market system, not an attempt to transform our approach to health care. Whatever anyone else tells you about Obamacare, go read it. You'll see yourself it's not there. Neither the federal Constitution or any state guarantees health care for all. Some Americans have gone to court claiming a right to care. The legal theory that they followed is that our Declaration of Independence says we all have inalienable rights, including the right to life, and the argument goes, you can't have life without medical care to keep you alive, but no U.S. court at any level has bought this argument. In other advanced countries, there is no debate. All recognize the right to health for all as a moral obligation. We are the odd country out in this particular group, and it is something that we really have to come to terms with. Let me just give you my quick summary of what this is about. Social justice principles are very powerful in these other countries. Market justice remains most powerful in the United States. There are deep concerns about tax burdens here that often stop and stymie any reform. There are efforts to, quote, reform the tax code, remove the tax burden, forget about its unfair distribution and so on, and the lying and hypocrisy that's going on. But the notion is that we need to cut back our tax burden because that will make Americans more free. In these other countries, there are people who happily and willingly take on a greater tax burden because they know they get tremendous benefits back. They are willing to pay in more in taxes to get these social benefits back in the form of health care and other major services and access. That's part of the way those countries operate. In the United States, in our political culture, there is a strong bias towards private institutions, which are presumed better, more efficient, etc. And in the U.S., but in other countries, go to any of them, there is deep public respect for national institutions and national enterprises, from the train systems to the airline systems and so on, to the health systems. And those valuing of public provision is very different from our general, oh, look at that incredible train system, the national system in France or Switzerland or Germany, the trains actually run on time to the second. And we have Amtrak with its 7-hour delays, etc. They are very different attitudes. They're reflected in almost every dimension of our life. And we've got to acknowledge that and recognize the significance of that. Even where we do get important programs like Medicare and Medicaid, these are understood and justified as exceptions. They are correctives for market failure. Well, the market wouldn't properly cover the elderly who've reached retirement age, so we can come up with a special program for them. But that's an exception. Don't try to generalize it. That's the way it has played in the United States. Or Medicaid is for the poor people who won't benefit from the market, or maybe with some of the Obamacare extensions and cost sharing until they're taken out and destroyed by Trump and his cronies. These will help people buy into the market, get health insurance, but the whole notion is that these social programs are plugs, patchworks, patches, in a system which remains fundamentally market-driven. Not so in these other countries. They don't see that the market is any particularly good thing. In fact, it does and has done historically, in many instances, enormous harms. In this country, even with the Affordable Care Act, when it's in full throttle, the goal is to fill in holes, plug leaks for vulnerable populations. It is not, AIM never says it is, an attempt to create universal social programs, as is the intent and the reality elsewhere. So these are some of the things that we will explore starting next week with T.R. Reid, his book, and the closely related film. But before we get to that, I want to do a little bit of a detour first to understand, help us understand that this is only part of the story of health reform and health distribution. There are very many other ways of looking at it, and there are some other major events in the world that are related to massive health reform and health improvement that are not part of a liberal democratic process, that may in fact be part of a revolutionary process, and that it may in fact be that revolution can be the friend of distributing health care much more effectively for the vast majority of people. In fact, I offer you 3 major examples of revolutions which were in large part motivated by and realized major positive changes in health care for the majority of the population. In chronological order, they were the Bolshevik Revolution in 1917. They were the Chinese Revolution that was in effect fought over many years and concluded in the late 1940s. And there was the Cuban Revolution. In each case, revolutionary leaders were strongly committed to improving health care for those citizens, and saw that one of the great impediments to health care for all was a stratified, inequitable, top-down structure that privileged the wealthy and ignored or exploited the poor. They were fought against highly stratified societies in which there was a clear stratification of class, interest, and opportunity. And if the people in these classes, the upper classes, were the ones that benefited and took the wealth of the country and applied it to their own ends, and the people who were suffering, the vast majority, lived down here in the lowest strata. The leaders of those revolutions, and don't forget that Che, as an important leader of the Cuban Revolution with Fidel, did you know that Che graduated from medical school? Did you know that Che was deeply committed to medical reform not only in Cuba but throughout Latin America and the world, as a principle, a positive principle of change. Change through revolution. The only way forward in a society which is so corrupt and top-heavy and enforces its privilege for the upper classes by military rule and torture and disappearance of would-be critics and rebels. In any case, in such societies, the only way to help these people is to put them on top or closer to the top. There is no democratic mechanism for doing that in societies which are holding on to their power and don't have democratic institutions. Whatever institutions they have are shams or shells or non-existent. And you have ruling juntas or ruling czars, etc., ruling emperors, who are going to continue to hold on to power and benefit and distribute it among their favorites, while these people get left out and simply die. The only way of changing that is to turn that society upside down, which is the definition of revolution, which means radical change from the roots on up. And that's the revolutionary idea, with a very significant commitment to health revolution that motivated the leaders of the Chinese and the Cuban, and we'll see soon, the Russian Revolution. This comes at an opportune time. I am very pleased to continue as the history editor of the American Journal of Public Health, and I'm delighted that our new editor-in-chief, Alfredo Morabia, very interesting man, MD, PhD, epidemiology, MD from the University of Geneva in Switzerland, PhD in epidemiology from Johns Hopkins, very well qualified, is the editor-in-chief. And Alfredo not only has bona fide credentials, he also has political courage. Last year, he did an anniversary issue in October, celebrating the founding of the Black Panther Party, because new scholarship has clearly shown that the Black Panther Party was not just a, quote, terrorist organization, but was very strongly committed to principles of social justice, and one of the main agenda of the Black Panther Party was to create storefront clinics and to try to address unmet needs in the black community. There's a very good sociologist named Alondra Nelson, who is now a dean at Columbia University, who has written a book about that. And it was honoring Alondra's work that we had an issue talking about some of the positive contributions of the Black Panthers on its anniversary occasion, 50th year then. Well, here is the November 2017 issue of the American Journal of Public Health under Alfredo's courageous leadership, to which I contributed a few pieces, etc. November 2017, celebrating the 100th anniversary of the Bolshevik Revolution. That's Lenin as he appears on a subway mural in the Moscow subway. And inside are a number of important articles, including an editorial by the great Russian historical scholar Nikolai Krementsov, who was born and trained in Russia, is now a professor at the University of Toronto. His wonderful books on the history of medicine and healthcare have been published by the University of Chicago and Johns Hopkins University Press. And he and I together edited the papers in this edition. Nikolai writes an introductory editorial, which I will read to you little bits of next time, so that you get a sense of how he sees what the Soviet Union accomplished. There were many people in the 1930s and 1940s who, in the United States, looked to the Soviet Union as a model healthcare system, a new model created by its revolution and those committed to achieving healthcare equity for those who had been previously denied in the old Russia. And they saw this as the vision for the future, saw America's system as hopelessly implicated in the system that was collapsing around them and that needed the New Deal to shore it up and to protect people living within American capitalist realism as it was playing out. Now, there is a book which has a very sensitive reading of that material. It's the new textbook of international health, Global Health in a Dynamic World. It is the principal textbook on and my view on international health issues in general. It's published by Oxford University Press. It's just coming out with a new updated edition. And the lead editor of that is Anna Manuel Byrne, a friend, colleague, and co-author of mine, the same Byrne, of Byrne, Brown, Fee, and Lear, same Anna Manuel Byrne. She is very fond of Nikolai Klementsov and appreciates his perspective. In fact, she's his wife. So there are interesting sort of connections over here. Anna Manuel Byrne and her two colleagues, Yogan Pillay, who was a Minister of Health in South Africa, and Timothy Holtz, who was a physician and has worked in global settings around the world. They all have in common they were all students, graduate students at Johns Hopkins School of Public Health, and they all started with a man named Vicente Navarro, who has a very powerful perspective. They sort of channel that perspective on healthcare systems in this book. And in the chapter on international health systems, they very much have this notion of stratification and the way in which revolutions can reverse stratification in a positive sense for health. Their chapter 18, I believe it, or 12, what is it? I forget the number. It's on the blackboard. Chapter 12, Understanding and Organizing Healthcare Systems, is very different from anything you'll read anywhere, except in maybe Vicente Navarro's works. He's prolific, many, many books to his credit. Because they begin essentially with the notion of stratification. They begin that the only way you can really understand what happens in many societies is to adopt the perspective of political economy. Who has the wealth? How is it distributed? Who is privileged by it? And that then is reflected in the basic healthcare arrangements. One of the keys to their chapter and their understanding is something that they talk about on page 589. Which they, borrowing from an English author who invented the term, call, it's partly sardonic, it's partly ironic, it's partly a joke, it's partly to hit you between the eyes, the inverse care law, which they attribute on page 589 to an English scholar, a man called Tudor Park. Read it at the bottom of the page. The inverse care law is not to be confused with Newton's inverse square law. That's something entirely different. And you've all learned about that in physics or somewhere. We all know about the inverse square law. The inverse care law says, its basic statement, well, let's read what they say about it. 589. This is the key to their chapter. They say, the distribution of health resources may not relate to need. According to the inverse care laws proposed by Julian Stewart Hart, quote, the availability of good medical care tends to vary inversely with the need for it in the population served. This operates most completely where medical care is most exposed to market forces, and less so where such exposure is reduced. In most countries, the rich spend more on health care, or the state spends more on health care for the rich than the population most in need. So a simple way of stating the inverse care law is this. Those who are privileged, who have wealth, who have access to other resources and benefits of society, those who need health care least, those who are wealthy and privileged, those who need health care least get it most. And those poor, at the bottom, sick, struggling, who need health care most, get it least. That's the sardonic, the ironic inverse care law. It's not a statistical synthesis like certain social science laws. It's more of the sardonic variety of Parkinson's law. Essentially all procrastination, that work expands to fill the time needed to complete a task, procrastination. Or Murphy's law. Basically, if anything can go wrong and get screwed up, it will. At Plus universities, very significantly. It's a law of that formulation. It's an ironic, sardonic recognition of reality. Inverse care. Those who need care least because the most privileged get it most. Those who need care most get it least. That is the way the world is structured, which says the world ain't fair. It ain't fair within stratified countries, and it ain't fair in the world at large, where the global north, where most of the wealth of the world resides, gets most of the care and other benefits, and the global south, solace and access to antiretroviral medications and AIDS and so on, sub-Saharan Africa, get it least. Those who need care most get it least. Those who need care least get it most. It is a statement of the unfair reality of the world, and informed by the inverse care law, there have been those who have been motivated to say the only way we can change things in certain situations is to undergo a revolutionary transformation, making the healthcare needs of the bottom one of our top priorities. So we'll have to stop here.